So I'd like to welcome everyone to the meeting this morning. We will do introductions later before the item begins, but we've got some housekeeping that we have to go through first. So we're not expecting a fire practice. If the alarm sounds, can all present leave the building as quickly as possible by way of the nearest exit. And the designated assembly point is in the public square in front of CAST, beyond the fountain and away from the civic office. If there's anybody with mobility issues, please wait in the refuge area at the top of the stairs where the emergency evacuation lift is located, and use the intercom situated to the left-hand side of the lift doors to call for assistance. No roll call will be taken. So I'd like to just check that everyone's got the mobile phone switched to silent mode so that we don't have any accompanying music. The meeting will be audio-visually recorded and will be available to view on the Council's website and YouTube channel. And can I ask everyone present to use the microphones to ensure the audio can be captured properly. Any members of the public entering the council chamber are accepting that their images will be retained and broadcast by the council. And if there are any public in attendance, and I don't think there are at the minute, if any member of the public or press is intending to record or film any part of today's meeting, please ensure that this does not disturb the conduct of the meeting. And if you're visually recording, you are requested to only focus on recording. We're going to look at the NHS Integrated Care Board update. And can I ask for an introduction from attendees, please?
Morning, everybody. My name's Anthony Fitzgerald. I'm one of the executive directors for NHS South Yorkshire Integrated Care Board. I'm responsible for our Doncaster patch, and I'm also the senior responsible officer for primary care across South Yorkshire. And my colleagues?
Good morning, I'm Debbie Stovin. I'm the dental programme lead for South Yorkshire.
Morning, Carolyn Ogle, Deputy Director of Transformation, part of South Yorkshire Integrated Care Board based in Doncaster.
Good morning, Victoria Linden, Deputy Head of Primary Care in the South Yorkshire team, here to talk to you today around community pharmacy. Thank you.
I'm Phil Holmes, I'm the Director of Adults Wellbeing and Culture in the Council.
Morning, I'm Rachel Leslie. I'm the Acting Director of Public Health at Doncaster Council.
Martin Greenhouse, Tickle and Wadworth Ward and Vice Chair of this committee.
Glynis Smith, Chair of this committee.
Councillor Laura Bluff for Bessica Ward.
Councillor Julie Grace for Roman Ridge Ward.
Councillor Sue Knowles, Armthorpe Ward.
Councillor Jake Hazley, Town Ward.
Before we start, I've clearly missed some things off, so I'll just quickly go through those. So have we got any apologies for absence?
No apologies.
Okay, and what we're going to do is consider the extent, if any, to which the public and press are to be excluded from the meeting, and there aren't any issues on this agenda. Are there any declarations of interest? No. So we need to accept the minutes of the last meeting. So can I have somebody to agree and second those minutes, please? So public statements, a period not exceeding 20 minutes. I don't think we have any public here. And there are no items where the public and press wouldn't be included. So can we start please, with the first presentation.
Okay, so I'm just going to kick us off. So first of all, thank you for the invite, certainly very timely. We are going today with our resident experts take us through three areas really that we, in response to the request from the committee. We're going to talk about general practice in Doncaster, both in terms of the current situation and some of the work that we're doing, particularly in terms of improving access to general practice. We're going to talk about pharmacy, which has been the responsibility of the ICB since April, and some of the work that's going on there, and also dentistry, and particularly in light of the national announcement yesterday, we'll set that in context of some of the work that we're doing in Doncaster. What we'll do is a very real picture of the current situation. We've obviously been to other committees around the council, such as Health and Wellbeing Board, but we'll set the context of where we are at the moment and some of the improvements that we're trying to make. We felt it best to chunk this up, so we'll do. Are you going first? Are you, Victoria? Oh no, we'll do general practice first. We've obviously received a number of questions already from committee members. We'll pick those up, and any others that we have there. Then we'll go on to community pharmacy, do the same, and then we'll go on to finish with dentistry, and we'll pick up any recommendations, Chair, after each of those sections. You've had quite a detailed report. We're trying to flesh that out more in the slides that we've got here, and we'll also make, I don't know if they've been made available, Caroline, but we'll make those slides available at the end. Thank you. So we'll get into it. We won't PowerPoint too much, but if we can get through the slides and then pick up the questions as we go along. Okay, so we're going to start with general practice, and over to Caroline.
Thank you. So the National Plan for Recovering Access to Primary Care was published by NHS England last May, and its main aim really is to stop the need for people to have to call back at 8 o'clock the next morning just to get an appointment, and also for people to be clear when they do contact their practice, whether that's by telephone, walking in or online, what's going to happen with their particular case. There's 4 key areas in the plan, which is about empowering patients, modern general practice access, building capacity and cutting bureaucracy. So what I'm going to do is take you through those themes as they apply in Doncaster. The first bit I want to do really is set the context around the demand that's out there already. It's really important that patients who need to access their general practice can do so in a timely way when they need to. So included in the report, and on, it's actually the first slide, but is the context in which we are working. So demand is very, very high for general practice appointments. When you look at the figures included in the report, so I included October's figures, but the slide, when you get them, you'll be able to see it includes November. It equates to over half of the population of Doncaster each month accessing a GP appointment. In October, it was 58%. If you look at the purely on numbers, some of those will be people going repeated times. The data doesn't include our same-day health centre, which is available for urgent on the day. It doesn't include GP out-of-hours appointments. And it also doesn't include any patient interventions that aren't classed as appointments. So when you get a call back about results, letters, tasks that practices do. So they're not included in those numbers. But it does include our additional access appointments. So enhanced access is available every day, 8 till 8, and on a Saturday, 9 to 5. They're also included in there. The graphs just show the fluctuation in demand, really, mainly on the increase since COVID. But there's also seasonal variation, as you'd expect. In August, tends to be less demand than in October, November, as seasonal sort of infections start to rise. The other key actions to empowering patients are promoting the use of the NHS app. So if you can imagine, if we can get more people to use the NHS app, that will free up telephone time for people that need to use the telephone. So all of our primary care networks have a target of trying to get 75% of their population using the NHS app. They're at around 50% at the moment, which is quite good for most of the population, but they've still got further work to do. Another bit is around how do we increase self-referral so that people can self-refer to particular specialties without having to go through their GP. So for things like hearing aid appointments or some wheelchair services, some physio, podiatry, those kind of things. We're looking to increase the ability for patients to self-refer, also for weight management type services. And also for things that can be done at home that we don't need to see your GP all the time. So during COVID and just after, we purchased blood pressure monitoring machines, for example, that patients can take and monitor their blood pressure in their own homes and just alert when there's issues with that. And also the expanding pharmacy services, which we'll hear about later on. The second bit about implementing modern general practice, there is support funding available nationally to support practices to look at their capacity and their demand so that they can change their model of how they work. We've had 10 of our 37 practices so far put forward to do that. It is voluntary for the practices to do it, but we are in the first year. So in the second year, we're hoping that more practices will come on board. However, it's not intended that every single practice will do that because the national funding wouldn't provide that for every practice. Some of our practices are already working on a modern general practice model. There's also the issue of telephony. We know we've got access issues with people being able to access their GP by telephone, and there's a big push on moving to digital telephony. Everybody has to move on to digital telephones by March 2025 because analogue is being switched off, but they've accelerated it for GP practices, and there's been some national funding available to support practices to move on to the new system. So this will enable patients not to get an engaged tone when they phone, to understand where they are in a queue, and also potentially to have a call back when the line becomes free. So that, again, it will increase capacity of the phone lines, call back facility. We've got 19 of our 37 practices that have moved very quickly and signed up to those new contracts. Some have already moved across onto cloud-based, and others have got very long existing contracts with their current suppliers, so we're supporting those to move further later on. We also are working with a company which is looking to help practices to maximise the usefulness of the new systems and actually look at the benefits of that change. The most obvious benefit is that they can see what the demand is. You know, on the big screens, they can see how many calls they've got at any one time. At the moment, they're working a bit blind. So you as a patient might be ringing several times, but the practice don't know that. So it'll give us much more intelligence about the demand out there and how we need to respond to that demand. So the way we are ensuring delivery is that requesting that all 5 of our PCNs develop capacity and access improvement plans. So they've all got those in place. And this includes, there's a list of things on this slide that we're expecting them to do. It includes them making sure, for example, that their websites are user-friendly, they're easily accessible, and that you can find things quickly, that patients can book appointments, order repeat medication, and contact the practice online as well as on the telephone, and also be able to access their medical records should they wish to do so online. Care navigation training, we've provided our own Doncaster bespoke care navigation training. So that's to ensure that our admin staff in practices know how to advise a patient, actually be better seen elsewhere rather than coming into the practice and directing them accordingly. Sometimes patients might ring a general practice for a dental issue, for example, or for an ear care issue that could be dealt with by a pharmacy, or for a minor ailment. I will come on to talk about digital inclusion work to support those people who need help using technical support. One of the key things, obviously, is patient experience. You know, we do all this. We need to make sure our patient experience improves as a result. So there's a heavy focus on the capacity and access improvement plans on how does our patient survey improve, how are the friends and family scores looking, making sure all our practices are actually offering friends and family to their patients so that we can get that data. And also making sure that the appointments are being mapped so that that table at the beginning is a true reflection of what's actually being done, so that everything comes through on the national data. Building capacity, that's about working much more differently and sometimes in multidisciplinary teams. We've already got good examples of where we do that around care homes, for example. And there's lots of additional roles now in primary care. At the end of March 2024, we're expecting that we'll have over 200 roles that didn't exist before the primary care networks came in, doing different roles like physio, pharmacy, physicians associates, etc. And also health and wellbeing coordinators, social prescribers. There's a national target to increase the number of doctors to 6,000, and in South Yorkshire we've got a big focus on retaining GPs that might leave if we didn't keep them locally, and there's a lot of good work being done by the South Yorkshire Workforce and Training Hub to support our staff, particularly through supporting supervision techniques, coaching, mentoring, preceptorship programmes, etc. Clearly, more capacity means we need more space too. And I think I've been here before to talk about some of the premises developments that are happening in Doncaster. So plans for a new build at Bentley and Rossington, but also some extensions of practices. So Petersgate's got a new extension on it now, and the Scott practice isn't far behind. So that's enabling more staff to be accommodated in existing practices and it to be used wider than just that particular practice footprint too, so that we can share that space and with our partners. Enhanced access I've mentioned, so we've got enhanced access appointments in place across all 5 PCNs, which increases the ability for patients to access appointments in the evenings and at weekends. And one of the things that we've struggled with in the past is how do we know how busy our practices are? In a hospital, it's quite easy to understand when a hospital's busy because the beds are full. It's really difficult to understand from 37 practices, but now we've got a tool that gives us that intelligence. So all the practices now complete what we call a capacity and access demand tool, and that feeds into our meetings around pressures across the system. So it tells us how many, if they're feeling the pressure for urgent appointments, feeling the pressure from telephone appointments, routine, etc. And anybody that's struggling, we then have the ability to follow up with them to see how we can support and make sure that they're resilient and responding to their patients. Cutting bureaucracy. There's national work to try and reduce the number of targets that practices have. There's a review at the moment around the incentivisation part of general practice, so the quality and outcomes framework, for example, looking at whether that's doing what it needs to do, looking at reducing administrative functions that practices do, and a particular focus is looking at the interface between hospital and primary care, so that we're not sort of removing the burden, pushing the burden somewhere else, and there's things that hospitals can do to help primary care by making sure that referrals are done onwards, not back to your GP to be referred to somebody else, and also cutting some of the paperwork around that. And some of the non-clinical work that GPs are asked to do, like providing sick notes for jury service, is also being looked at nationally, for example. Digital inclusion. I know there's a lot of focus on digital primary care in this slide, and we had a question around digital inclusion. I have sent some pictorial information through to Caroline with some case studies on it, which we're happy for it to be shared. That shows our work with Age UK for working with older people to help them to use the NHS app if they would like to do so. And we're running sort of basic digital skills courses and having NHS app drop-in sessions for people in practices and out in the community, just to show how the NHS app can work. We've tried to help those most likely to be excluded or disconnected, including elderly people. And all of the primary care networks have digital and transformation leads to support this agenda. We're also making sure that we've got some refurbished kit, so refurbished tablets are being provided to practices to support patients with registration, so they learn how to register themselves online without having to go into the practice with a form. Our 6-week skills course have now been extended to 10 weeks. People are really finding it beneficial. And we are supporting care homes around the digital offers. We've got somebody in post who's actively giving that proactive support to care homes, and we're hoping to widen that further. The 400 people that I referenced in the paper is now 850 people we've got funding for to support through digital skills, and we've already got 735 people enrolled in that in the 12 months. It's a mixed composition of people. It's not just about older people. There's the people with protected characteristics, all genders, and we'll analyse the data that we get to make sure that we're covering the population appropriately. The criteria for inclusion is you have to be 18 and older, either referred by one of our trusted referrers, so one of our partners, a voluntary organisation, or you can self-refer for this support. We've offered it to the Deaf Society and people with complex lives, and we're also working on tailoring courses for people from Black and ethnic minority communities. So what these courses does is it's helping them with skills, but also building their confidence and improving their basic understanding of what the digital support can do. And it also demonstrates the benefits of time. So if you do this, you don't have to hold on the phone to ring the practice, but also you're helping other people who need to ring the practice to get through. Also cost efficiency, because it's free to use, And also, importantly, people are being trained on how to stay safe on the internet too. We've had really good impact, 96% increased confidence, 94% increased skills, and 95% better understanding of the app. So as I say, the intention is that it reduces the overall pressure on telephones and practice time. So I'll stop there in case there's any questions.
Okay, so thanks. There's a lot in there. Hopefully that's given a flavour of what the current demand and pressures are, but also an idea of what we're trying to do across a whole range of elements locally that links to the National Recovery Plan. Now, we have received some questions already, Chair, so shall we go through them and then come back? So do you want to pick them up, Carolyn?
I can do. I can do. I think oh, sorry, Caroline. Yeah.
Sorry, of course.
Okay, yeah. So the first couple really are from me. So I'm kind of really interested in the physician associate role. And I am reading in the reputable national press and also in, magazines and from some of my ex-colleagues. We've discussed it, the role. So I'm wondering who has the responsibility for supervising the physician associates, that we're not, putting an extra burden on the GPs in the practices. And I think it's really important that it's made absolutely clear when patients are seen by this role that they're not seeing a doctor. I've already said that I have spoken to people that I know really quite well who were expressing concern around the role.
Thank you. And I think that part of the question was also how many have we got in Doncaster. So by the end of March, we are anticipating that we'll have 12.5 whole-time equivalent physicians associates in our practices. So not every practice by any stretch of the imagination. And I think the thinking behind this is to free up GP time to be able to do some of the stuff that GPs do. So physicians associates can take histories, they can do physical examinations, they can diagnose patients, they can see patients with long-term conditions, as can nursing staff. They can analyse results, etc., and provide advice. They have to be supervised by a doctor. It is a postgraduate course they undertake for 2 years, but they must be supervised by a doctor. The intention of that is, as they gain experience, work longer in the practice, there's less supervision requirements. They won't be sitting with them all the time and wasting an appointment of their own, if you like. It's to provide that advice and support when they need to, as they gain in experience. And as we've said, over 200 different roles now in Doncaster working in primary care. Some of that capacity is absorbed by some of our other healthcare professionals. Patients are usually told who their appointment is with and explained the nature of that. Obviously, we don't police that through all 37 practices, but I would like to think that patient will be told who is seeing them. But what we've got to do is try and change the culture that it has to be a GP that you see. Some of our practices are nurse-led, some of them are pharmacist-led, and the GP is kind of, almost a reversed role from history in terms of, nurses leading that, and the GP sees the more complex patients, etc.
Can I just add to that? And because there'll be a theme throughout all the sort of presentations here. Clearly, given the demand that we've explained, we have to look at different ways of meeting that demand with the capacity that we've got. And some of that will be about enhancing other roles. It really gets to the heart of the additional role reimbursement scheme that we mentioned through this. Now, there has been some of the early evaluation of those additional roles. And I would say at the moment it's probably too early to tell. Because if you think about a practice, we need time to embed these professionals in that practice, don't they? So that they have the confidence with their GP supervisors, that patients have confidence in the roles that we've got, and that will take time. Part of the challenge we've got is to ensure that we've got the right incentives to retain those staff within those practices, so that culture can develop both patients and professionals. But I do think this is a good thing if we can get it right and really get those professionals embedded. And at the heart of this, it's about the appropriateness of that professional for that patient. That won't always be a GP. so that seeing the most appropriate professional is at the heart of all these recovery plans.
So my next question is, really, some of it's kind of been answered in your presentation, because the original information said that 10 practices had expressed an interest, and I'm aware that we haven't got quite as many GP practices as we did have. We now have 37, but 10 didn't seem to be, you know, a huge figure in the kind of scheme of things. So I suppose my question is, can the practices that are taking everything on board and have moved to a new system run alongside the other practices successfully?
Yeah, I think the answer to that is yes. We'd very much hope that those who have done it can really sell the benefits to the others. So we've got a practice now that is running a modern general practice system, Conisbrough Group, and they've done a lot of sort of case studies with their peers. We've also done what we called a practice improvement week with the Burns practice, and that was a dedicated full week looking at the demand coming into practice, looking at the letters that they get, looking at the things that were inappropriate, looking at the calls, and that's being shared widely as well in how can we learn from this. And there's a national general practice improvement programme as well. We've commissioned our federation to work with every single practice to see what their needs are, what support do they need, and actually promoting the modern general practice model. The thing is, for practices, I suppose the funding that's available is to support them to take time out, 2 weeks time out. So the funding is for backfill, basically, to really look at it. And it's really difficult when you're really busy to think you can take 2 weeks out to do this. But actually the benefits outweigh that time taken, and we just need to keep pushing and promoting that.
And my last question, I can absolutely see the benefits of moving things like screening and, you know, diagnostics to Mexborough site, to the site at Montague. And, you know, I can see the benefits because it's a cuddled site, it's not got the emergency unit, it's not going to be affected. I can see all of the benefits, but it is the other side of Doncaster, and with not huge parking facilities, and, you know, public transport around Doncaster, quite frankly, isn't the best. So are there any concerns around parking on that site that, you know, we're not going to turn the residential areas around Montague into the huge problem we have around DRI? And is there a possibility of any additional parking or other systems in place that could support that?
I'll take that one. I didn't think I could come here without talking about car parking in terms of the thing. So there's a lot in there, isn't there, Chair? I have sent that question over to Doncaster and Bassetlaw Hospitals, who obviously run the Mexborough site, particularly in terms of further developments, because we are trying to get the best possible use of the Mexborough Montague site. So people will have seen the opening of the EMIOC, which is the emergency orthopaedic centre, I think elective orthopaedic centre, which I think is a great thing for Doncaster and South Yorkshire. Also have seen the community diagnostic centre, which increases the amount of diagnostic tests that we'll get through there. Clearly then, what will be the impact of parking and capacity? So we're having to look at how we manage that appropriately. Equally, on the Doncaster, on the DRI site, we are increasingly looking now at the services provided from there and appropriateness from there, given on the back of the announcement around or lack of announcement around the new hospital site. So we are looking in collaboration with our council colleagues about the best use of estate across Doncaster, and clearly parking will be something we take into account there. Also, given what Carolyn's just presented, we are having a look at the best use of digital technology as well for these appointments. So recognise the risk, Chair. I have contacted the hospital. I'll get back to you particularly around about the Mexborough site parking. But it's an additional risk that you add when you try to provide more services across different locations.
Can I give you my experience? I've seen an associate, and I've rung up the GP for an appointment, and they've offered me that, but then they've offered an associate as an alternative, you know, somebody who's training. And so I've always accepted that. They do the check, come to the conclusions, then they go and see the GP, give them a briefing and the findings, and then the GP comes back, and if they're in agreement, then they're telling me what the findings are. So it does free up the doctor's time, because he's just coming in just to check what this briefing is. So it really does free up a lot of time. But like as you say, that the important bit is I'm offered an appointment with the GP, but then I'm offered the alternative, and then it's for me to choose. Right, thanks.
First of all, I want to say thank you, Caroline, for that beautiful, well-detailed presentation. So I have a few questions here. I'm going to go to the first one. It's regarding the table where you explain the statistics about people missing appointment and all. I'm just curious about what's included in that statistics. Is it just doctor's appointment, GP? Does it include nurses and other healthcare practitioners? Because I think we could infer some in conclusion on the statistics if we have disparities, you know, with the percentage of people missing appointment with other healthcare professionals as compared to doctors. Thank you.
Yeah, so the table shows all appointments, so GPs, all healthcare professionals, anybody that is sitting with a patient or has a telephone consultation or a remote consultation with a patient, that's all their appointments. The breakdown for October was 36% was seen by a GP, 62% was another healthcare professional. What we can't give you is the breakdown of those who don't attend by healthcare professional. What we have done, though, in the past is one of our MPs was interested in how an area of Doncaster was faring in terms of DNA. So we did go to the practices and ask for that breakdown of information. And we've also done it around enhanced access. And actually the results were quite surprising, that the appointments that were not attended were the GP and nurse appointments rather than those that were specific and specialist by other healthcare professionals. So, for example, go and see a dietitian, probably a better understanding of what you're going to see that dietitian about. For example, they were more well attended than some of the GP and nurse appointments. However, the DNA rates are significantly less in our extended access appointments now, following that analysis.
Thank you very much.
So, sorry, can I just come in there? So you might have seen in the presentation, do not attend rates do equate to, you know, over what was it, 8,000 patients?
Yeah, there's over 10% of people are offered appointments, aren't taking them up, which is, yeah, I should have emphasised that, I meant to.
Thank you. And that's just going to lead me to the next questions, because I love the presentation about the digital advancement and, you know, upgrade for GP practices. I've received text reminder for my appointment before, and I've received your automated text to confirm your appointment and all. I just want to know how consistent this is, because sometimes I do receive reminder, sometimes I don't. Due to my knowledge of digital technology, I know that these kind of processes are automated and rules set behind tools that nobody just needs to do anything once the rules are made, except anything happens in the system, it should automatically get done once somebody get booked on, or once the rule to say, once it's 1 week before. It's as simple as setting up alert on your phone to remind you of an appointment. You don't need to go back to that phone to press anything. Once you set it up there, it reminds you at that time. So, because I'm thinking that if these rules are in place I believe that it's going to reduce the number of do not attend. If people are getting reminded of their appointment all the time, there's consistency in it, or maybe also improvement in it as well. If we are doing it 24 hours before, could we increase it to an hour before? Or could we increase the frequency and all? So it would be nice to know what goes on around that bit of process.
Okay, thank you. All of our practices have the ability to send text messages to their patients. However, what we're doing at the moment is trying to get the balance right, because it costs us as the ICB money every time a text message is sent. And at the moment, it's £15,000 a month, and it's increasing because more and more of that is being used. That's not to say it shouldn't be used where it's needed. And I think going back to the empowering patients, it's really important that patients take some responsibility too, to note when their appointment is. And it might be that you can ask the practice, actually, can I have a text reminder for myself, so that they're not blanket sending them out, and people that don't need it and have the ability to have their own reminding system perhaps could do it themselves, for example. So there is that too. But yes, all practices can send text messages to patients should they need to, but we're trying to look at reducing those that aren't needed. For example, Merry Christmas to all our patients. That's not a key message that you need to have, but actually reminding appointments might be key, especially in specific communities where we know that actually will help with the DNA rate.
Thank you. In my response to that, because I was actually surprised it cost you more money, because I've delivered CRM projects on telephoning before. And I know that it depends on the contract. I don't know who your service provider is. Certain amount comes with a package, and they are usually huge amount for huge organization. And whether you use it or not, you don't pay less if you don't use it, but you don't also pay more. There are tools that are there for you to customize and use for your needs. But perhaps maybe the number we're dealing with here is bigger than what's in that threshold that is free. So that might be the reason why it's costing more money. And I can understand how it has to be proportionate and used for the right reason. Right, okay, so that takes me to the next question, and it's also on digital inclusion, and this has to do with the use of the NHS app. You've answered most of the questions that I would have asked. You've talked about the collaboration with Age UK, the training that is being offered by the GP practice. Now, the only question I have regarding that is, how are these promoted to the general public? How will I know if I'm not seated here today and I'm digitally excluded and I need this kind of training? How would I know where to go? Who are the gatekeepers for these digitally excluded people that you are collaborating with, apart from Age UK? And those protected characteristics and the referrer you've mentioned, because we believe that it is more than that. And you talk about the 400 people that were selected that has been increased to 800 now. You mentioned the criteria that was used. I'm just wondering how you were able to identify those people with those criteria that fit into that 800 box. Thank you.
Yeah, we have a digital team that are really enthusiastic and really sort of promoting the use of the NHS app, because they can see the benefits of us running with this, and it's out there everywhere. So all of the voluntary community sector organisations that are appropriate, it goes through there, because people can be referred through there, through our partners organisations, and particularly through the practices. The practices hopefully will be promoting it too. I'm not sure about national publicity. I think I've seen some sometimes around the NHS app, but perhaps not as much as it could be. But that's how people can self-refer. And we're working with the Doncaster Skills Partnership, I think, to promote it too. So it is out there.
Thank you. I'm really quite proud of the work that we're doing around digital inclusion in Doncaster. We're not necessarily the experts here, but if Chair, you wanted a future agenda item on that, I'd make sure we get the right people here to promote some of the work that we're doing, because we're seeing some real benefits, particularly reaching out to some of our population that we wouldn't have done before.
I think we would be interested in that, Anthony. Yeah.
I just want to ask about this training. Where's the locations for it? Is it in the practice itself, or are you seeking locations?
I haven't got all that detail. I think some of it's in the practice, particularly for drop-ins about the NHS app, but there are community venues that are being used. The leaflet that I've sent to Caroline has some of the venues on there across Doncaster, so you'll be able to see when that's circulated.
It's just that I would be interested in hosting one myself.
All right.
And it's in a hall next to the GP practice, so that would be great.
We'll put you in touch with Kate.
Thank you. Can I just add to that? I know that Chair has responded to that, but from my personal experience, I've been invited by faith groups before to offer digital inclusion trainings. So when I mentioned the gatekeepers, those people that have access to the digitally excluded people, it might be worth checking with them. As we know, a lot of elderly people attend churches and other faith centers as well. And since COVID, there's been increase in remote church service. I was at church on Sunday, and there was a family that did 60 years wedding anniversary, and the gentleman was joining us on the screen at home because he couldn't come while the wife was at church, and then there was a huge celebration for it. And that's just the beauty of digital technology. So I'm thinking that there will be a very significant stakeholder in terms of promoting that. So that takes me to my next question, which is on reducing the burden of the GP. I quite agree on transfer of some responsibilities that are taking up the time of the GP, but I want us to look at how we can risk assess, because there are so many instances where the medical notes of patients don't transfer from the GP practices to the hospital. I've been in front of doctors in hospital before, and I'm telling them about situation and tests I've done and medication, and they can't find it on the system. And if that is the case, if we are transferring that kind of responsibility, when people or the professionals are making medical decision on patient, they need to have an holistic view of their medical history so that we can avoid mistakes. They need to know about the allergies, they need to know about the medication, they need to know about the test and everything. So when transferring responsibilities, I would want us to look into that and also know if there has been any risk assessed on what we make decision on transferring and the impact on that.
Again, that's probably another one for our digital director, but we've been working really hard on trying to integrate our Doncaster Care record. I'm not quite sure where we're at with that. It's taken a lot of time to try and get that together so that you do have one record. However, at the moment, obviously GP practices have their patient records, and there's more and more now electronic communication between a hospital and the GP practice. So if they need a test doing, it goes onto an ISA system, for example, and it gets sent to the hospital. We are trying to move away from patients having to repeat their history every time they see a healthcare professional, so that it's done once, and that's around our personalised care agenda. So yes, we appreciate we've still got quite a bit of work to do around that, but I don't know if you want to add anything, Anthony.
No, I also appreciate we've got a lot of work to do with that. Some of the complaints that I see from patients are not rarely around the quality of the intervention. It's very much around the communication and particularly around the interaction across organisations. As Carolyn says, we have put a lot of work and a lot of expense, quite frankly, into the integrated care record, but we've got further to go in that. Anything to do with NHS care records, as you can appreciate, is a complex area. Also, as part of the primary care access recovery plan, Carolyn hinted at it, is a whole work stream around reducing bureaucracy and that's actually getting right to the heart of the communication between general practice and secondary care, such as the hospital, to make sure that the right information is getting across, that the right person is picking up, such as reporting results to a patient, for example. So I absolutely accept we've got more to do in that area, but we've got the right work streams on it.
Chair, have we got people to ask the remaining questions? Yes. I think that Caroline has answered that question regarding the 400 local people. I think the next one would be the remote consultation. So I can put the two together. Is that okay? Oh, yeah. So my next question is regarding the percentage of remote consultation that the GP provides. Is there any statistics or information about that? And also, can the number be increased as an interim solution to housing the workforce? Oh, no, fine, thank you. So I've listened to the expansion of GP practices and the project that is going on. But I'm wondering that if we if we know the percentage of the remote consultation for GP, practices, if we can increase this or enhance this maybe through digital tools, can this be used as an interim solution to the issue that we're having with housing workforce?
Yes, thank you. That's definitely something we're looking at. So at the moment, when you see the slides with the table on, you'll see that 75% of all the appointments every month, roughly, are face-to-face appointments, and only 25% are not face-to-face. So that's either by telephone or online consultation. So there is some more work to be done in terms of increasing that, but also looking at other consultation methods. So group consultations, for example, for people with long-term conditions, to free up each individual having an appointment. And that's something that practices have started to do around diabetes care, for example, so that they can do that once instead of several times. But yes, during COVID, it all went remote, didn't it? And we don't want to lose that sort of momentum of going back to the old way of doing things. It has to be face-to-face. Some patients, and a lot of the surveys say that patients do prefer to see somebody face-to-face rather than remotely. So we've got to balance patient need and ask with actually supporting the capacity in our practices too.
Thank you. I think it might be worth offering patient the options as well. Just like Councillor Julie mentioned that she booked an appointment with a GP and she was offered another professional, because people might change their mind. So lastly, this is just a recent experience I had with a GP. I booked an appointment to see the GP for an urgent case. I was offered appointment at another GP practice, separate from the one I usually use, which I accepted. On getting to the appointment, I was seen by a nurse. When the nurse assessed my case, decided I needed to see a doctor that day. So gave me the number to the same day health center, and I called them. On calling the same day health center, there wasn't a single doctor appointment available for that day. So instead of booking me in to see another nurse, which is going to be a waste of time because they have to refer me to a doctor, they refer me to accident and emergency. So I had to move from the first appointment the same day and to accident and emergency, where I spent close to 13 hours. Now, if I had known right from the beginning that I would be going to accident and emergency, I would have gone earlier instead of going for the first appointment with the nurse in the first instance. I had to leave around 3 a.m. to go home. And I think that that is just not fair on anybody. to spend that long to see a doctor is not acceptable. So I'm wondering the use of this same-day health center, if there's actually not enough practitioners or professionals to be seen. I'm wondering if it's possible to have a ring fence of, like at the back end of ring fence of professionals that could be brought in, so that when you have cases like that, at least you get to see a doctor. Because if I get to see a doctor at the urgent medical center that day, all I will be referred to were the tests because I had to go through a lot of tests at the hospital on that day. So, and going for those tests were not that difficult and didn't take much time. All you have to do is show up, get the test done, then go and see the doctor again. Then you get taken to the next place to get the test done. So I don't know what your views about that is.
I mean, it's quite difficult without going into details of the case, but it'd be interesting to know how you were triaged when you contacted your practice. So did they take enough information to know how urgent your case was? Because it might have been that it was an appropriate place to go to emergency department, as you've suggested in the first place. I don't know without knowing those details. The same-day health centre generally do have appointments every day. We've increased the demand over winter. We've got, particularly for patients with respiratory problems, so they've got additional appointments on at the moment until the end of March. But we do look at the demand and how well it's used and which practices are using it too, and whether that's appropriate. I'd also be interested if it was appropriate for primary care, for example, were you offered an evening appointment, or if it had to be the same day, were you offered an evening appointment? Because practices do have appointments up to 8 o'clock. Not every single practice. It might have been a different practice, but there might have been capacity in the enhanced access service as well.
On that, I mean, apologies for me. I agree with you. That's an experience that isn't good enough. We're not talking about ED department today, but the knock-on effect of your experience is that you've had a long wait in there, and clearly the wait isn't appropriate. But is that the right place for your care in the first instance? I was wondering if we could take that conversation outside of here, Carolyn, get in touch with you, and just so we could take some learning from that. Because when I saw the question, like Carolyn, I was surprised, because actually we're trying to drum up more attendance at our same-day health centre, because we do see appointments going fallow there, and yet people are having different experience. So I do think there's some learning we can take from that. Apologies you had that experience, but if Carolyn can contact you and we can get some more information.
Yeah, that's fine. Thank you very much. That's it from me.
Okay, so I think in view of the time, we're going to move on from this one. So if I could just say that, some of the figures that were in there were a lot higher than I imagined, particularly for October. And I think that we'll only know from the outcomes, really, how this is progressing. So we would, as a scrutiny panel, appreciate update on the outcomes, really, so that we know where we are in Doncaster and what's happening.
That's absolutely fine. I'd had a look at, sort of jotted down some recommendations as we've been going through that. What I've captured is you would value a digital focus at a future meeting. I'll make sure that's done. I've definitely taken away the point around better communication, both with the patients but across organisations. And in terms of your last point there, this plan is only as good as the difference it makes, isn't it? And we're happy to give either written or come again to the committee to see on the difference that's making. Which takes us on to community pharmacy and Victoria.
Thank you, Anthony. Thank you. I'm going to be my own assistant, if that's all right, just because it's probably more straightforward. So in terms of community pharmacy, what we sort of thought we could cover today with you, and looking at the questions that were asked, was some updates around access to community pharmacy, and some key things to sort of talk you through on that. I think there's also something, and as Anthony said, there's lots of themes through this. I think it's also important to get across some of the demands actually on community pharmacy as well, and what that means. And then as part of the primary care access recovery plan, to talk about the new Pharmacy First service, which is a nationally agreed service, but what we're doing in South Yorkshire to implement that, if that's okay. So in terms of access, as I say, there were sort of some key things that we just wanted to sort of talk you through. So I think, again, in terms of a theme, we know that community pharmacy as a team, and I think it's really important to sort of emphasise that community pharmacy is not only about the pharmacist, but it's about pharmacy technicians, and it's about the wider team that work in community pharmacy. And we know that they are that they have a range of expertise and skills, which I think it's fair to say previously hasn't really been fully utilised. They are absolutely experts in terms of medication. So one of the things that South Yorkshire is currently involved in is an independent prescriber pathfinder programme. And this does focus on the pharmacist role, and this is about recognising that actually pharmacists, when they're doing their degrees to qualify and when they're working in a pharmacy, they absolutely understand medicines probably better than anybody else. And actually, and again, you may have had experience of this yourselves, sometimes patients do go to their community pharmacy, they do seek advice, and the outcome of that is actually that they need a prescribed medication. And up till now, the case has then been actually, I'm sorry, but currently you need to go, therefore, back to your GP practice to obtain a prescription, to go back to the pharmacy for the pharmacist to then dispense that to you, even though actually the pharmacist knows exactly what is needed, exactly what the medication is, but that's been the sort of the process up until now. So what the Independent Prescriber Pathfinder programme is about pharmacists having that prescribing role, so that actually that trip back to the practice is cut out of the process, so that you can go to talk to your pharmacist, they can diagnose your illness, your ailment, they can talk you through the medication that you need, and they can therefore then prescribe it and dispense it to you all in one visit to the pharmacy, which would be a great improvement, I think, on how things have been in the past. So we have a number of sites, I think it's 10 sites in total across South Yorkshire, including in Doncaster, where we are part of this programme, because as you can appreciate, patient safety and governance and making sure that everything that needs to be in place is really important. So the Pathfinder programme is to make sure that actually all of those things are in place, so that we can grow this role, and pharmacists across pharmacies and any pharmacy can have that capacity to provide that service. The other thing that we just wanted to mention was around locally commissioned services. So much of what community pharmacies provide are agreed nationally, so they're negotiated and agreed nationally. As South Yorkshire, in the same as every other ICB across the country, obviously we've come together, so we've previously had 4 clinical commissioning groups, we've come together as a single South Yorkshire organisation, and obviously partly that means that we have got some differences perhaps. So for example, in Doncaster, certain services will have been commissioned and agreed locally, which might be different to Barnsley, to Rotherham, to Sheffield. So what we've got at the moment is a piece of work to kind of, I think firstly, understand what we actually have in place across the 4 places now. Understand what they are, understand how they operate, understand how they link into other local services, and understand actually there may well be reasons for having slightly different services in place, but if we can make sure we've got that really clear understanding of what they are and how they work, and then actually are there any opportunities to expand that. So for example, if there's a service in operation in Doncaster that's not in place in the other areas, is there some scope to say actually we need to expand that, and obviously the other way as well. So for example, if there was something in Rotherham but not Doncaster. So I think that's a really important piece of work to undertake. And then I suppose the third thing to kind of cover on this, and again, I'm sure you will have probably had some experience of this yourselves, is that actually there have been some changes around community pharmacy, particularly over the last probably 12 months or so. And I think, again, in terms of themes that Anthony and Carolyn mentioned in terms of general practice, you know, that there are pressures in community pharmacy. We know that there are pressures in terms of the workforce. It can be a really difficult place to work. You are very much on the front line of things. Patients can come in with worries, anxieties, concerns, sometimes expectations around the promptness of how they'll be able to access services and receive their medication. So it is a really difficult place to work. And that does mean that there are pressures on the workforce. So I think, and we've sort of described some of the changes there, what community pharmacy as a sector, if you like, as a group have done is to kind of have a look at particularly the opening hours that they operate across, and to do some work to understand actually when are the sort of times of perhaps really particular demand? When are the times when actually there are perhaps few patients coming to the pharmacy? And then there's been some work which they've done to then kind of consolidate some of that and say, actually, let's try and perhaps consolidate our hours, let's focus them, reduce them a bit, so that we're not overstretching ourselves and actually run the risk that we're sort of stretching ourselves too thin. I think the other thing that's important just to say on this, so we do work closely with our colleagues at Doncaster Health and Wellbeing Board in terms of the pharmaceutical needs assessment, which is a document which the Health and Wellbeing Board publishes and renews at least every 3 years. And that's all about understanding what the provision of community pharmacy is across Doncaster, not only in terms of locations, but opening hours and the services that are provided, and to look at, to say, actually, are there any gaps? Are there any areas where we need to develop services or increase service provision? So although there have been some changes, and the paper that hopefully you've had a chance to have a look at does describe some of those, but all of those changes are shared with health and wellbeing colleagues, and we are working with them to see actually what the impact of those changes are, and is there any action needed to address any of those. I think, as I've mentioned, in terms of the demands on community pharmacy, there's kind of two sides to this in a way. I think there's a really wide range of service delivery in community pharmacy. I think there's a range of what's called essential services. So these are very much that kind of traditional model of community pharmacy. So the dispensing of prescriptions, the being able to go and ask the pharmacist for some advice, possibly sometimes purchase a medication rather than needing a prescription. Obviously, they also provide, as I say, support for self-care. They do support patients to dispose unwanted medicines, so perhaps medicines that have gone out of date, or medicines that patients have perhaps not decided to take the full course of. And they also do support patients on discharge from hospital. So quite often somebody may go into hospital with one list of medications, and then whilst they have their care at the hospital, they come out and some of those medications change. So community pharmacies then support patients to understand this is how the medicines have changed, this is how you need to perhaps take them differently, or how you need to sort of monitor as you're taking them. But then the other side of it is very much about expanding the role of community pharmacy. So absolutely that role of dispensing medications and all those things they do is absolutely still there. But as we've talked about, actually they can do a lot more, and they have expertise and skills to do a lot more and provide a lot more to patients. So there are things like blood pressure checks, being able to go into the pharmacy and have a blood pressure check. If it's fine, lovely, that's great. Actually, if it's suggesting there's something that needs follow-up, then liaising with the GP practice, sharing that information so that the patient can do that. In Doncaster, as well as across South Yorkshire, community pharmacy has played a really key role in the delivery of flu vaccinations, which is obviously quite a long-standing service that's delivered each year. They've also played a really critical role in the COVID vaccination programme. So we've had community pharmacies providing this service not only from within their community pharmacy premises, if you like, but also setting up and running from community venues as well, to really, help with accessibility to that really important vaccination programme. And they've, as I say, played a really key role in that. Also things, another example would be around contraception services. So again, going back to some of the things that Carolyn was talking about in terms of accessing practices, there are lots of patients who go to their GP practice to request a repeat prescription of their contraception, for example, to have perhaps an annual check. Community pharmacies can now do that for patients and support them with that. So actually that's a number of patients who aren't perhaps on the phone trying to get through to the practice for something that actually the pharmacy can help them with. So this is where we try and sort of put this all together, really. I think in terms of workforce, again, as we've touched on, this is, across all services, across all of the NHS, but for community pharmacy it is a real issue, I think. So for South Yorkshire, we have a pharmacy workforce strategy. And it's got, as you can see there, the sort of 4 key themes. So there's something about how we can sort of have a sustainable workforce for the demand and what's happening today and currently. How we actually have a sustainable future workforce as well. So as these developments are coming on, how we retain existing staff. So I think there are lots of developments coming on. As I say, there's kind of 2 sides to it. So on the one hand, that makes community pharmacy a really exciting place to work and a really different place to work. but clearly when you're being asked to perhaps do more and develop your skills and keep your skills up, actually that can feel a bit of a pressure at times as well. So actually how do we help to keep people who are working in community pharmacy already? And then, as we say, the opportunities for the expanded roles. So how do we really make use of all the expertise of not only the pharmacists, but the pharmacy technicians and those other roles as well, to make community pharmacy a really exciting place to work, and to really make use of their skills. And then Carolyn did touch on this, but just as I say, in terms of the primary care access recovery plan, so again, you will have no doubt probably seen recently that on the 31st of January, the Pharmacy First service was launched. So this was a service that was negotiated and agreed nationally, but obviously South Yorkshire and in Doncaster, we then have a sort of a plan about how we implement this. So this is very much, as I say, about making the best use of community pharmacy, particularly around minor illnesses, so that patients can go directly to their community pharmacy with a minor illness, as I say, and have the conversation, be diagnosed, have the discussion about the medication and the best way to treat it, and have that medication provided to them all in one appointment, as I say, without that, what can sometimes feel like a bit of a ping pong back and forth between the pharmacy to the practice and back to the pharmacy again. Community pharmacy has really pulled out the stops on this in terms of signing up. So in Doncaster, there are 70 community pharmacies, and every single one has signed up to say, yes, we want to provide this service. We want to work with you to provide this service. And I think they are really keen to make the best use of their skills and to provide what they can. As with anything new, it's not perfect on day one because life's not like that, but we are working really hard both with our community pharmacy colleagues and with Doncaster's local medical committee and with our GP practice colleagues to actually say, okay, we need to work together to make this work. It won't be perfect, but let's make it work. Let's see how it's going to work. How are we going to resolve things if actually things don't go completely according to plan every time? How do we work that through? How does the practice and the pharmacy work together to resolve any issues rather than sometimes the patient feeling like they're having to go back and forth and resolve it? So it's a really positive thing. In terms of communication, so as you say, you may well have seen some media coverage in the last sort of week or so about the service. I think it's fair to say that it was intended to be I guess a bit low-key to start with because we want to kind of get the service up and running. We've been advised that there are plans for a national communications campaign to start probably towards the end of February to raise awareness and make people aware of the service. And again, we are also working with our communication and engagement colleagues within the ICB to complement that for South Yorkshire. So there'll be some national information, but also some local South Yorkshire and Doncaster specific information as well. I think that's me done, if that's okay. Thank you very much.
Thank you. Just to the last point, I take this as a real positive. 70 practices, 100% sign up in Doncaster. I think we've got to make this work. And what I would add is that we're not starting from scratch, are we? This is on the back of many schemes that we've run on this. So particularly for those 7 things that are mentioned there, I think that could be a real improvement and reduce some of the burden on GPs. So again, Chair, we've had some questions in this area.
Thank you. That was really good. Thank you. My question is a bit more of a wider question, and it specifically came out of the bit on page 6 that says that 15% of current GP appointments are able to be navigated out of practice. I find this whole thing really interesting, and especially, Anthony, what you said about, I think you referenced is changing the culture of who is the most appropriate person to see, and I think that's a really important thing to highlight. So you might have covered some of this already. But my question was, how do you see the role of community pharmacists evolving in context of the plan's objectives? You talked about a national information campaign. I think that probably there is some sort of maybe education that needs to be given out. Because I think it goes back to like a really kind of sort of old kind of... sorry, I'm losing my words now. Like an idea that, the person you want to see when you've got a problem is a GP, the nurse assists the GP, and that's all, and that's it. When actually what we're trying to move to is that there's a whole host of different types of people that you can see, and you need to see the most appropriate person. So yeah, that was the question. Thank you.
I'll take this, and then you might want to just expand. I think we need an open and honest conversation with our residents. and I've talked to Health Watch around this, and I'd appreciate help from counsellors, because the offer is changing, counsellor. You know, some of it changed for the better as a result of COVID. We've talked about some of the digital elements, but I keep coming back to that word appropriateness. And I would like, and we've talked about this with our primary care teams, an open discussion with our residents that say, we've got many different ways of accessing appointments. We're trying to get the most appropriate professional. We're trying to improve our communication across professionals, so that you're not telling your same story to 5 or 6 different people. But that might include telephone appointments. It might include digital appointments. It might include going to your pharmacy rather than your GP. And we'll communicate that well with you. What we ask of our residents is, you think about the most appropriate choice, and please keep your appointment when it's given. So I think there is some work to be done in that area. More, but better than what we've done previously, which is a kind of communication campaign to say, this is what's out there. Much more a kind of sort of discussion and roles and responsibilities of both the professional organisations and the residents themselves about how we make things fit for the future. I hope that wasn't too woolly, but I do think that's the area that we need to get into. In terms of how pharmacy can help with that, though.
Thank you. So I think it is very much about, I don't know if the word was traditional, I think you might have been thinking of, but there was that traditional model of community pharmacy, which is very much around dispensing of prescribed medication, and there is that. And community pharmacy will absolutely always have that role, and that is absolutely needed. But I think in terms of how it will evolve, it is about actually as I say, the pharmacist, the pharmacy technician, the wider pharmacy team have so much more in terms of skills and expertise, and actually really utilising that. So, you know, it is about, they are the absolute experts in medicines. So if you do have a minor illness and actually you do need to talk to somebody and you do need a consultation, they have consultation rooms, so you can go into a private area if you'd like to, rather than being stood in the main pharmacy area. You can talk that through, they can diagnose that, and they can then advise you, right, this is the medication that you need. As I say, it's a prescribed medication, but I can prescribe it to you, so you can leave with that. Or there's some remedies that perhaps you can consider purchasing them instead, sort of thing. So I think that's what it comes down to. It's absolutely having that core role, but it's expanding that and really making use of the pharmacy team and all the skills and expertise that they have.
Thank you, that's great. I just wanted to add, actually, and traditional was the word I was probably looking for. I think, it's really good if we can, look for new ways to work. I mean, it's going to sound like a really silly kind of anecdotal experience, but it was before COVID, and I'm not one to advocate for the United States health system, but I was there, and my partner at the time, she had an ear infection, and we had to go to a pharmacy because it was kind of the only option we had at the time. And in this particular pharmacy, I don't know if it's the case across the country, but they also had nurses there. So if you take away the side that we had to pay for the appointment and do all that, we walked off the street into a pharmacy and then subsequently saw a nurse, and you wouldn't get that over here. So I think there are lots of ways that we can try and make things more dynamic, and you can get things in different places and get away from that sort of one, I need to go to the GP model.
Under the new scheme, I would suggest, without knowing the exact case, that your wife could go to around year 8 to the pharmacy now under this. Okay,
that's great. Thank you.
Right, can I just go over Pathfinder again? Is that unique to Doncaster, or is it a pilot that they're trying sampling everywhere?
So it's a national programme, so every ICB has been asked to participate in it, and what we've done is to work with, so it's a bit of a pilot really, to test it and see how it works and pick up any issues. So we've got sites across South Yorkshire, but we have sites in Doncaster, so there are a couple of pharmacies in Doncaster who have pharmacists who have chosen to undertake that prescribing qualification, but haven't really had much opportunity to use it really. So they're part of the pilot to say, right, this is how we could use it, this is how it would work, this is how information would flow between us and the GP practice, for example, to really sort of test it, see how it works, see where things don't work and what we then need to do about it. So it's across the country, it's across South Yorkshire, and it's in Doncaster specifically.
So clearly this is looking to expand. So if the I could say practice, the clinics on a small footprint, what support's being given, because they'll be looking to expand, won't they? What support's given?
Yeah, absolutely. So because it's a pilot, obviously it's just in a couple of places, but we're trying not to restrict it, so patients would be able to use those pharmacies. It's just that we're not piloting it in every single pharmacy. So in terms of the support, it's about, as I say, working through them. So how would they help
Sorry,
patients?
you've misunderstood.
Oh, sorry, I beg
Yes.
your pardon, sorry.
No, if I owned a chemist and it was a small little chemist, but then it takes off and it starts to expand, and these premises aren't enough for what you're looking to achieve, what support as a chemist going to have as a business to be able to move, to be able to grow, to be able to provide the community?
Right, okay. So I suppose the ultimate aim is that actually this would be something that all community pharmacies would be able to provide. So whilst some community pharmacies, and a bit like Carolyn mentioned in terms of general practice estate, there's a real difference. Some of them have lots of space, some of them don't. But the intention would be that we want to have this so that all pharmacies can provide it for all communities that they serve. And we would need to, I guess, look at the terms of support in terms of the physical space that they need and any other support. And that's part of that Pathfinder pilot is, as I say, to kind of, this is how it works and this works great. Actually, this works okay, but needs some support, and this is what the support is. Or this really doesn't work and needs lots of support. So that's all of what the pilot's about, is to test it all and to see where the support is needed. Apologies, does that answer the question? Sorry.
Right, the other thing was... am I right again to carry on, Chair? It was just about testing, so like water samples and things like that. Is that something, an area that they'd be moving into?
So yes, this is again about part of expanding the role, and I think this does feel quite different in terms of being able to do this at community pharmacies. But again, this is part of where we're testing things to say. So, for example, could you go and have a blood test at a community pharmacy? How would that work? What facilities might they need to do that? How would we then get the blood test to the laboratory and so on? So it's about expanding the potential of community pharmacy in a really wide sense, but we do need to work through the implications of how it would work and what we might need to do to make it work. Thank you. Thank you.
Thank you for that. So if I just kind of sum up and bring that together, I think that's extra. I mean, as a, we think that's very positive, particularly the full sign up from all the community pharmacies, because it can be very different in other areas. And I think the key thing here is around communication and how people know where this service is available in the early stages, and then later as it grows and increases across Doncaster. So I think the communication to the general public, and obviously to vulnerable groups and to the whole of our communities, is going to be absolutely key on how we get that information out there, so that the public are confident about the use of, the pharmacy as an alternative, and what that service can provide. So that's going to, make the difference in how people attend and the outcomes. We would ask for an update as a future work plan on the outcomes of the system.
Thank you. So in terms of communication campaign, we'll be doing a lot of that over the next few weeks. So look out for that, and we appreciate sharing that wherever possible through the forums that you've got. The proof's in the pudding again, isn't it? So we'll be looking at that evaluation, particularly from a quantitative perspective. But if you do have feedback from your constituents, and that we're always wanting to hear that, so please send them myself and Victoria, and we'll keep the committee updated. So we saved the best till last. So we're on to dentistry now, and Debbie's going to take us through it. some of them are going to escape. You're going to escape, aren't you, Carolyn, from me? Yeah, and that's fine. Okay, so dentistry. Debbie.
Hi. Yeah, I think we have saved the best till last, and obviously there's been some national announcements this week as well, which I think were news to us as well. It's like I'm working my own slides now because they're escaping. So we focused this on the areas that we were asked to look at. So we are covering quite a bit, but I'll try and sort of work through the slides quite quickly because we did have some information in the report and give more time for questions. I have started just with some of the initial bits just to sort of set the scene. Some of you will have heard this before when we came to the Health and Wellbeing Board back in December. As we all know, good oral health is essential for good general health. We have got high levels of tooth decay and oral health in South Yorkshire and obviously in Doncaster. Pain and infection, we've sort of slide covers some key bits in there in terms of what it does affect, and it does affect quite a bit. It is largely preventable, so we'll come on in terms of oral health and fluoridation later on. And we do share some common risk factors there in terms of sugar, tobacco, alcohol, oral hygiene, and these things are all preventable areas. Children's teeth for 5-year-olds experiencing tooth decay. These are quite startling figures, and some of you will have heard them before. But you know, it is a significant area for us for children. We have got high levels of tooth decay, and in Doncaster, as you can see there on the table, we are showing much higher than other levels in South Yorkshire. All health for adults, so the other end. We have got 30% of adults experience tooth decay and greater proportion of moderate and severe gum diseases than national. So not just on children where we've actually got high levels, we've also got that in older adults, and we've got an ageing population, as we all know, which is going to bring us some additional problems in order to be able to sort of address the needs for adults. I'm trying to work to lots of notes here. We've got the access rates, which look more pleasing for us in Doncaster. As you can see there, in terms of Doncaster against our other South Yorkshire areas, we are faring well. We're not back at pre-COVID levels in terms of access for adults and children, but we have got an increasing trend for that, and we are looking more positive. This is access for adults seen in the last 24 months and for children in the last 12 months. Against national, we are obviously looking much better. That doesn't mean to say that we've achieved everything in Doncaster. We certainly haven't, but it is a positive that we are actually looking in a better position. National. So as well as the announcement in the last couple of days, national, there has been some dental contract reforms because our dental contract is not fit for purpose, as many people will say. So nationally, there has been some changes made already, which we introduced in the summer 2022. There are some more planned changes for stage 2, and they're still being discussed nationally. So we are expecting some further changes, which will introduce some regulatory change and other changes. And they've also been mentioned as part of the reforms that have been the recovery plan mentioned this week. The dental budget in the NHS is to be ring-fenced to 24-25, which is really positive. It will allow us to be able to reinvest funding that we actually get through under delivery of contracts. Dental contracts, we do get an awful lot of under delivery for various reasons, so actually being able to utilise that funding for other schemes on a short-term basis, because this will be on a sort of an annual basis to start with, and we're obviously looking at where we can actually make that into more long-term planning as well, utilising that. But it is something we're very much working on and developing plans locally within South Yorkshire. Just to add, in terms of the national dental reforms that have been recovery plan that's been announced this week, there's obviously a lot of emphasis there in terms of access and easier access, and look at incentives for dental practices to actually see more people and let more people access into dental. We know a lot of our practices have got significant waiting lists. So obviously these new incentives that have come round in terms of being able to receive an additional payment on top of their normal payment to see new people is an incentive there for practices. It's all very new, we're still working through it and we're still waiting for a lot more detail to come through, but some of those changes are actually due to start in March 2024 and run for a year's payment. And there are other elements in there that have been announced this week. Well, like I say, we're still working through that detail and we'll be able to look at those alongside our local plans as well, because they're not to mean that we'll stop developing our own local ones because we've got the national ones to come through. We need to sort of look how they work together and look on how we can sort of progress with those. Flexible commissioning. We spoke about flexible commissioning before, and it was a big emphasis on our South Yorkshire event we held in November. Flexible commissioning means we can work with the dental contract differently and also help the practices to be able to use a wider skill mix within their practice and look at offering something other than your normal appointment, going for your checkup or to go and have your extractions or fill-ins, whatever it is. And it just means that we can actually work very differently with that. It is quite limited at the minute, and we've got 13 practices in Doncaster working in that way. And it's going to give the ICB much more to be able to be a bit more ambitious and work more innovatively and look at actually utilising those contracts slightly differently as well. So that's going to enable us, and I think one of the questions raised as well was how we're actually going to be able to work with some of those more deprived neighbourhoods and more vulnerable groups. And this will enable us to do that, and that is the plan that we're working on currently. So we'll be able to target those practices in high needs areas and work with practices in those areas by using this different way of commissioning and being more transformational, really. We will have to be looking at the practice performance and what they're doing now. We know a lot of practices have got workforce challenges. That's an issue not just in Doncaster, but South Yorkshire and nationally. But it just means that the practice can work away from just employing people to work on the current mandated dental contract in that way. It's not as attractive. Actually working differently, doing some more targeted work, working with different neighbourhoods and different groups is more attractive to some of the dental associates out there to come and work in a practice. And we've seen that in some of the other schemes we've had running and starting to do. We've got a bit more work to do on it. We're still working on what the outcomes are going to be from that and how we can actually link in with the deprived areas, looking at the practices we need to concentrate on. But there's been a lot of progress on the development of that. And we're about to sort of take some schemes and papers through the governance routes and through executives and through to our board later next month. Workforce, again, we're using the flexible commissioning approach is going to hopefully, as mentioned already, supporting the workforce to do that. And it just also gives the practices that opportunity to try and recruit and retain the workforce. And one way we're going to do that, we've got a programme of work looking at recruiting overseas dentists. We have had overseas dentists working with us before. Some of that has sort of ceased or become really difficult with COVID and with Brexit. So it has sort of meant we've not been able to do it. There's not been a lot of that happening, but there's some schemes working at the minute, and we're developing a scheme to actually try and make it to be able to do something with that. I know some of our corporate providers are also looking at that themselves and looking at packages of support and supervising within practices to make sure we've actually got the right environment for people to actually come and work in the NHS. Benefits of flexible commission, I've already mentioned a few. It also helps improve patient access because we can work on a different way. We can work on a sessional way rather than an appointment way. A lot of people that are coming into the areas, particularly the ones that have not been able to access dentistry before, take longer. They take longer appointments. They may need to come back for multiple appointments. So working in a different way means that we can actually accommodate those patients within the practice. So it makes that better use of that dental workforce, utilising the skill mix and the capacity, because there's not just a dentist within a dental practice, there's hygienists there's dental nurses, etc., with other, with a wider range of skills, just like we spoke about with GPs and within pharmacy as well. It helps morale and retention. That's the feedback we've had from practices that are already working in this model, but the model we're trying to push forward will actually make that a wider offer. We'll be able to utilise a bigger part of their contract to actually work in a sessional way and work in a flexible way. It helps improve oral health inequalities. We can target those deprived areas. We can target where we know we've got some inequalities. And it should then reduce the under-delivery within the practice. And actually it will then reduce the clawback, their underperformance, which then means we will get less money back to actually work with and do things differently because we're working within a ring-fenced amount. But actually to actually have the work happening in a local area and actually meeting the needs of that population is much better than just having under-delivery and having money then we need to look at doing some sort of short-term schemes with. There are some challenges with that. Obviously, we know we've got a difficulty in the state of NHS dentistry. There's a big challenge regarding workforce and retention of dentists, so that's why we're trying to do something differently. So that can have a limitation. We know that. The national contract, as I said, is really difficult. It's a huge challenge, and that's accepted everywhere, really. So it's about making us work better and working differently. We have obviously got time frames to work with, but we are quite keen to get something running and up and running in this next year. We have got some initiatives in across South Yorkshire and in Doncaster particularly that are helping to strengthen and improve access to dentistry. The homeless pilot is only recently started in Doncaster. It started in being operational from November, and already we're hearing really, really good positive feedback from that. The dental practice we've identified, it was in the Flying Scotsman. They're working with local charities, voluntary sector, so they help and accompany people to come into the service. They're already they're finding all their sessions fully booked. They're already now booking into April. They're seeing people coming in and being smiling and coming into multiple appointments. And, feedback is that it's starting to change people's lives, and it's only been running, we're into the 4th month, so it is really, really positive. Urgent access sessions, I know there was a question in there about why we've only got one practice in Doncaster providing these urgent access sessions. That was purely by the practice in Doncaster not responding to the offer, and that could have been for various reasons. They may just not have been able to sort of accommodate doing anything more than they're already doing. They may have workforce challenges. They will all have their own reasons for that. That is that we've only got one at the minute, and that's providing urgent access sessions. So it's providing some of those appointments through to 111. So they've got some additional appointments they can offer in the area, but also for people that are actually contacting that practice directly, who've got an urgent need. So it's supporting that overall urgent access that we need in the system. Our urgent access generally is significant. We have got such a high demand on urgent access, and we have obviously got limited appointments in the system for people to go to who need the appointment. Not everybody who rings 111 for the dental line will need an appointment. They may just need some advice. But where we do get those calls and they're actually allocating an appointment, we have been able to sort of manage to allocate appointments in Doncaster. Again, the Flying Scotsman is one of our main areas in Doncaster where the appointments happen, but there are a couple of other sites as well. We are expanding the urgent access schemes for next year. We're hoping that we can continue with those, and we will then be looking at re-offering that to practices and actually trying to target where we think there is a targeted need across Doncaster. So even though we've got one now, that may increase. We do collaborative working. So South Yorkshire and Bassett Law, the Acute Federation is Paediatric Innovator Programme. It sounds very long, but it has been identified for dental, and it's looking at transforming pathways and improving access for paediatric dental services. Our main focus at the minute is regarding general anaesthetics for children. For paediatrics, we've got some long waits for people to be assessed and then to actually get the treatment in Doncaster and other parts of South Yorkshire. So working with those to actually look at our pathways and look at how we can actually change those is what we're working at with and actually having the backing and the support from the Acute Federation is really sort of going to be driving that forward. Housebound patients, was another area. And in Doncaster, we do actually have a practice that provides domiciliary care. It is on a reactive basis. It's not a proactive service, but it is reactive, and they're working very well. The feedback I get is that it is working well. And we are looking, we've still got a working group within dental looking at sort of domiciliary care, particularly around housebound patients, to see what else we can do, see where we may have gaps. And that's across South Yorkshire. It's not just Doncaster, but actually we've got a good service in Doncaster. In interpreters and services for that, again, practices do have ability to actually use big words. So we do offer that as a service in Doncaster, and practices can use that, and that offers a range of those services I've listed there. We do find as well, though, hearing from practices that people tend to go in with, often with sort of relatives who are who, from non-English speaking patients, go in with a relative who can speak English. So we do find that patients tend to use do that as well, or patients will go in with other friends, family, carers, etc. But there is an offer there to practices to utilise it. And we do spend money on that, so it must be used. Mental health. We do have community dental services, and that's provided by the Rotherham Doncaster Southumberland Foundation Trust, and they provide that service for us in Doncaster as well as in Rotherham and Barnsley. That is there as a service that's referral only, so it is referral from other health professionals. That doesn't have to be a dental practice. It can be from others. There is eligibility for that service, obviously. So it is there for people with severe learning disabilities or profound mental health illness. But it is there, and it is a service that is there. There are obviously practices can deal with people with lower level of mental health issues as well. Electronic referral, so sort of looking at digital. Dental is a bit behind with digital. We don't have the same sort of national steer with that. Dental practices will have their own systems. However, we are developing, particularly because it was identified as a high priority, ability for dental practices to refer digitally for 2-week wait suspected cancer. At the minute, they're providing, filling forms in and sending them by email. Unfortunately, some of them probably send it by paper as well, but not many. But actually, we've been working with the South Yorkshire Cancer Alliance, and we've got a commissioned service already that does electronic referral management services in another part of Yorkshire and Humber, and we also have it for Doncaster for orthodontics, but we're developing that for 2-week waits. So that's a positive step forward, and we're hoping to build on that and make that functionality there for other parts of referrals from dental into the hospital for things such as oral surgery. That is part of our work going forward. It's on our local work plan, and we're working along the same lines with our colleagues in West Yorkshire and Humber North Yorkshire. That is a commissioned service across the whole of Yorkshire and Humber. Urgent care, touched on that already. Urgent care is predominantly via NHS 111. I don't know if anybody's rang with a dental issue. I certainly have. But when you listen to the messages on there, there is a dental line that you then press one of the keys for. It goes to our dental clinical assessment and booking service. There, they manage all our urgent care appointments in the system. So that is predominantly for those people who've not got a regular dentist, and I accept there's a lot of people who are in that position at the minute. Or if you have got a regular dentist but they may be closed, then again that's where this would work. People are triaged, and if they meet the need for urgent care through that clinical triage, then obviously they are allocated an appointment. And we've got appointments across the whole of Yorkshire and Humber, but ideally people are placed with appointments within where they live or where they choose the appointment to be in case they're working or whatever, for whatever reason. We have got a really good provider in South Yorkshire for urgent care appointments, as I say, predominantly from Flying Scotsman, so it's very accessible. We do have appointments for urgent care 365 days a year, so it is accessible whenever. And as I mentioned, the urgent access sessions that we have commissioned, again, they support this system. They're providing that level of additionality into this system. Ideally, the plan pre-COVID was that actually we would need urgent care appointments and with 111 less than we do, because people should be able to access routine appointments. However, COVID's obviously exacerbated the issue, and we've got a huge demand on the urgent care 111 line, which we look at, manage, and try and look at where our needs are. But Doncaster, well, South Yorkshire, but Doncaster is looking okay. I'm not saying it's perfect, and I'm sure there may be, you may know people who have been struggling to get urgent care, but we have got a really good system operating, but we are constantly looking at that level of demand. Fluoridation. I think, from the oral health figures we've got, fluoridation is key. We don't have fluoridated water in Doncaster, and I'm sure you've had discussions around this previously. It can help. It can help totally in terms of having the fluoride there will mean we've got less tooth decay. There is evidence out there around 5-year-olds in fluoridated water areas have got less tooth decay than in non-fluoridated areas. People from deprived areas benefit the greatest from this. There's no behaviour change required at all. It'll just be there. It'll be instant. It'll be in the water. So it doesn't need that educational aspect where a lot of things at the minute do. Evidence just suggests it's safe and it's effective. There will be some counter arguments, but the evidence that is there is mostly favourable there. The Health and Social Care Act 2022, it has changed responsibility from local authorities, as I'm sure you're aware, to the Secretary of State for Health and Social Care. But it is something that we would want to keep promoting at every opportunity we get, and I'm sure other members and local authority colleagues would be in support of that.
Thank you. So, hopefully that gave a flavour of the work that we're doing, but also the complexity of the dental arrangements. It's been an eye-opener to me, quite frankly, having taken this on some of the ways that this works. When I look at the amount of complaints and things that come to my desk, dentistry is the most volume. I'm sure you hear that from your residents as well. I want to be realistic about the things that we're doing around this. I'll be taking a paper to my board in March that tries to put this right at the forefront of the work that we're doing as an ICB. Debbie's hinted at some of the things I want to recommend, but one is to make sure that dental money is spent on dental patients, and the second thing is to really promote all those schemes that we're looking at in terms of access. It's a big ambition, but what I want to do is try to ensure that access is not an issue for residents, so that we can have a look at our more medium-term, long-term schemes and investment, because I'm sure Rachel will back me up here. This is a generational issue that we're facing here. We want to look at our work really going into our children and young people, and ensuring that this is an issue for them going forward. But I do want to be realistic. The national plan that was released yesterday, quite frankly, I want to get to the bottom of whether that's new money or not, as you can imagine. So there's work to be done. I think we're in the right areas, but this isn't going to be an overnight fix. So thanks for Debbie for the presentation. We've got quite a few questions on this, Chair, so should we get into it?
Yeah. Right, thank you for that. Right, and I really would like to commend you for your commitment to this, because in the short time that I've spent a few discussions with you over it, and that you've not sat back and you've got clearly the percentage that we've got in Doncaster is above the rest of the country, but you've just not took your foot off the pedal either, and you're really pushing this forward, and I find that highly commendable. But I do feel that also in Doncaster we have got a culture of dentists that are really there for preserving NHS dentistry and wanting to really committed to it and want to really drive it forward as well. So I think this could work really well together. Now, you've really made a mess of my questions, Debbie, because because basically I'm trying to find what you haven't answered. But in light of, I'm going to go to the last one first. In light of that the dentistry is the gateway to all health, and it impacts and the social impacts, because it's probably the only medical condition where it comes with some form of stigma, where it looks like a moral or economic failure and things like that, where other illnesses don't. You could be judged on it. This is your dental appearance, so it impacts work, academic achievement with being off. Health, it impacts recovery. So somebody who's going through these situations, they might not think about it's put it on back burner, getting me teeth sorted. That's how they'll see it. Where we see it as a improving oral health, which is that gateway. But because we're meeting these obstacles when trying to get access, so how do you communicate this with patients that it could solve or go towards solving other issues in their life when the resources aren't there to, at this point in time, but we're working on it, to help them along this route?
I think I understand the question. How can we get out to our public to say, look after your oral health and access services, when we're having an issue around access of services? Rachel, help.
Yeah, so we've heard and saw quite a lot about access to dental services. Obviously, the step in front of that is how to gain and maintain good oral health. And the local authority and public health teams in local authorities have some specific, not quite duties, but opportunities around oral health and oral health promotion. The one that will hit everybody and have an impact on inequalities is the fluoridation of water supplies, as been described. Obviously, water pipes, and we've heard that Doncaster water is not fluoridated. It sits under a South Yorkshire kind of network of pipes. It was previously, until 2022, a local opportunity, duty, responsibility around fluoridation. It was recognised nationally that it's difficult to make local-based decisions on things that affect neighbouring local authority areas. So that responsibility actually moved to the Secretary of State in 2022 for fluoridation of water. Doncaster and South Yorkshire did a lot around this, so actually we got to the point before it's moved to the Secretary of State where we're describing for South Yorkshire an efficient and operable scheme, so the investment in that engineering works to find out if it's possible and if it's affordable. That's happened, and that's gone and dropped as a package onto the Secretary of State's table to commence the next steps, which would be consultation with communities about fluoridation. So that is a real great leveller and equaler in terms of good oral health, positive impact on children, young people and adults as well. The other duties that we have, or opportunities that we have around oral health, are to build in oral health into our existing services, and a couple of examples of how we do that. So our Health Visited 0 to 5 service, we do things above and beyond what's expected in the national national service specification. So as part of the mandated visits, our health visitors go out to families with toothbrushing packs. So explain the importance of fluoride in water, explain the importance of starting to brush with the emergence of the first tooth, and we'll talk to them as well about technique and what they can do, a bit of troubleshooting if their baby is not liking the flavour of the toothpaste, and also reminding them about the importance of that checkup, so getting used to sitting in a dentist chair and counting the teeth, those bits. So that's the enhanced bit as part of our 0 to 5 service. We also have a small but effective supervised toothbrushing scheme. So there's evidence about what works for good oral health. So we have a small in-house public health team that go to early years settings and provide toothbrushes, toothpaste, the racks that they keep them in, and the training to the early years staff about a supervised toothbrushing scheme. So that would be a really positive, children sitting around in a circle brushing their teeth while they sing a song, to try and embed those good habits and knowledge of oral health in that setting, but also to give a chance for them to have their teeth brushed that day, and that kind of norm that they have. So lovely opportunity. We're lucky, actually, I know this is detail, but one of our brand new apprentices in our public health team is actually trained as a dental nurse, so we've collared her and got her out doing some of those supervised toothbrushing schemes. I know you've asked as well about languages, and I think when we heard the item at Health and Wellbeing Board, you were saying more ambitious, please, and more focus on inequalities for oral health. So our Healthy Scores information is information about oral health there, and that's been translated into languages including Roma Slovak as well. Let me see what else. Some of the broader things that were mentioned on the slides as well. So investment in breastfeeding as a protective characteristic for good oral health as well. So supporting breastfeeding through peer support groups. All of the work that we will and do around commercial determinants of health in terms of reducing exposure to high fat, salt and sugar being the particular worry for oral health. So all of those kind of place-based approaches that we can take to limit young people's exposure to advertising of foods that will not be good for their health, but also not good for their oral health as well. So I've talked a bit about those opportunities for 0 to 5s. You've heard about some of the things for access as well. We did commit at the Health and Wellbeing Board that we would refresh our oral health needs assessment. So what are we currently doing? What more can we do? What might the additional opportunities be through the announcements yesterday? So I think we need to look into that as well with some of those groups that you have talked about. So 0 to 5s particularly would also include people with learning disability, older people in residential care and people with a drug and alcohol use issue as well. So we'll dig into it through our oral health needs assessment refresh and look at what more we can do from that public health perspective for oral health too.
Right. The 15-year NHS workforce plan, it doesn't include dental nurses because they're not employed directly. But it does credit us, so yeah. But also, what I've seen in this one again yesterday were mentioned, which is great. What I have been searching for weeks, and I've got a colleague of mine that has been doing the same thing, we're looking for evidence about nurses that have left dentistry in these recent years. Now, we can't find, the way the GDC is set up, that doesn't tell you which way it is. We can't find the data. We have found some uni students that are doing surveys, but the data's not there, but we know it's happening. And like when they're putting job adverts out in Doncaster, sometimes they're not getting any responses whatsoever. Now, when I trained as a dental nurse, I was influenced by the experienced nurses around me. That they made me, I took it as a job, but they made me want to be a nurse and to live that dream, I think you might call it. I don't know if it's because they all had a house and a car, but that's the direction I took. Now, I'm feeling we've got these trainees, and I feel we've got a new generation, and we want, I'm all for supporting the new generation, and I'd love it if they've got nurses round them, experienced nurses, rather than all being thrown in at the deep end like it's happening. So what are you going to do to support leadership to want the nurses to come back? Now, I have looked at the BADN. I don't know if you've looked at that. The BADN, they did a survey. It was a small number. Reasons for leaving, it was like pay. It was absolutely no career pathway. And then it was feeling undervalued by the boss. When it looked by coming back, it was they did it for leavers or them wanting to leave. And the reasons for coming back, they didn't say more money. The reasons for wanting to what would come back was a change of culture. And so, yeah, they might say they've left because of money, but if they change the culture, it would be something that they come back to. So what are you going to do to support leadership into changing that culture to get all these nurses back? And can I have that nurse back you took, Leslie, please? Rachel, sorry. Yeah, could we have her back? To come back to dentistry.
I think that's a difficult one, isn't it? As you've already alluded to, dental nurses are employed by the dental contractor. but they play a pivotal role in terms of dentistry. And we would expect all dental contractors to have, to work within the environment of personal development for their staff within the staff team, and have those opportunities. I suppose one thing from our side of things with flexible commissioning, that is looking to promote best use of the skill mix within the workforce, and that's not just a dentist. Dental nurses have the opportunity to be trained as oral health need champions and actually do a wider role than just sitting in the chair with the dentist and supporting that that work in the room. And there is more of that happening. The LDC, so the local dental committees, have over the last couple of years had some funding to focus on workforce, and I know for a fact within that the committees have been funding extra places for dental nurses to actually undergo that training, either because they are becoming a flexible commissioning practice, or they want to do that, or just to actually upskill their dental nurses. And it's maybe more of a promotion around that sort of thing that we need to be encouraging within our dental practices, and our route in usually is through the local dental committees, and through the work we have with that, and through our local dental network in South Yorkshire, where we bring lots of people together as part of that membership, including LDNs, including the NHSE's workforce training and education team, formerly known as HEE, Health Education England. So that's part of other NHS changes. And so they're the ones that generally put a lot of the training on that dental practices, dental nurses can sign up to. Often those courses we did find were limited in number, and they were across Yorkshire and Humber, which is why the LDCs took it upon themselves to utilise that funding to enhance opportunities for their dental nursing team, because they themselves want to retain, they want to recruit and they want to retain their skill force, don't they, in the workplace, and actually dental nurses are a key part of that. So I think by working with them and us recognising the investment that they can make, and we also build that into our workforce planning going forward as to what we can do to sort of support practices to retain their workforce, is going to be one of the things we need to build into our plan. We've got a piece of work trying to develop that much more local plan for South Yorkshire ICB, working with the ICB lead and linking in with the dental school, obviously your main training area for the nurses as well as the dentists to go to, and with our NHSE workforce training education colleagues as well. So we have got discussions starting, but I take your point, we need to provide that leadership and make sure that nurses are not a forgotten quantity. So I've got a meeting coming up, so I'll certainly be picking that up as well through that route, Julie.
I was a bit disappointed that the national plan didn't sing more of other professionals and recruitment and retention into that. I think your question was around what more can we do as an ICB on this. I think we can promote and celebrate more where it's working. So I've been to a lot of dental practices, had a look at their flexible commissioning schemes, and they're being run by dental nurses, and they're really infused by the by the schemes that they're doing. But it does come back to the issue, doesn't it, about how we give space and how we give sustainability to practices through use of the funding to be able to run schemes and take on staff and train them more to be able to do that. So I think one role of the ICB is to lobby more nationally on actual promotion of these roles, and they need to be taken seriously and they need to be supported.
Thanks for that. What you're saying about the commissioning, it is more reflective of what I remember as being a dental nurse before the new UDA system came in, and it does sound very reflective, and that did feel very rewarding as a career.
Certainly, yeah. So we did only have the one that initially came forward. I am hearing that there is interest through the local dental committee, that there may be other practices that are wanting to join that opportunity. So part of our planning going forward is to look at where we actually need some maybe some more targeted access work utilising this scheme. So it's not just addressing the urgent access, it's addressing access generally then into practice environment. So part of our plan going forward is to get support to be able to continue with those schemes, utilising the money that we've got to be able to reinvest and open that offer up again. And what we will be doing is making sure that the LDCs know when that's all going to happen. We're very much now having those open conversations with LDCs. Myself, Anthony and Margaret Naylor as chair of our local dental network are meeting with them on a regular basis and in contact and utilising those as well to support where we actually want to use that investment. This is one of the key areas we would like to continue investing. So we have got one. I'm hoping we will be able to sort of expand that out. We do need the work, we do need the practice to come forward though. And as I say, they do have their own challenges, but hopefully we will be able to sort of expand on that going forward.
If we can make this national policy announced yesterday around additional incentive to take on patients who haven't been seen in the next 2 years, and that may be a way for us to do that. But as I say, I just want to get to the bottom of is that new resource or not, and how incentivising will that be for dentists? Debbie knows this better than me, but obviously for dentists taking on people who haven't been seen in the last 2, 5, 10, 15 years, it's really intensive work that they need that is involved.
Thank you for that. The flexible commissioning programme, and again, if you've already answered this, I apologise, I didn't pick it up, but you've said that of the 13 practices which accept referrals of children at high risk, the assumption is that they're being referred basically by health visitors, single point of contact, the looked after children's team and former community dental services patients. There must be surely children who fall through the gaps, who aren't referred by any of those people. So what are you doing to find that most deprived, most difficult group?
Okay, so as well as the service site that you've already mentioned, also that's going to be including school nurses, so that would hopefully then capture another cohort of children out there. We would expect all practices to prioritise any child that comes forward in terms of being in pain. We do push that and expect practices to do that no matter whether they're flexible commissioning or not. And I suppose one of our options as well is in terms of when we're doing the widening and looking at the other opportunities for using flexible commissioning, it's looking at where we have actually got those communities that are highlighted in terms of areas of need. I suppose it's very difficult to say how do we capture children that aren't captured by the areas, because obviously they are the most vulnerable, they are the most high, at high risk. But there'll also be work that's undertaken by the services that Rachel's already alluded to in terms of oral health and the oral health prevention that they do as well, to reach a number of children out there. That won't be captured by these groups, but actually just in terms of that wider prevention agenda.
Could I just expand that a bit? Unfortunately, there are children whose parents and carers reject all contact with agencies of any description. Not all children even go to school. I know we're talking about the very, very lowest group, but those children do exist. Have you thought of any way of sort of getting into that?
Just so I understand then, so are you mean in homeschooled children, or more likely our children in our more deprived communities?
It would include homeschooled children, yes. But also children from deprived communities. I mean, you're aware of the fact that there's some people who just reject all contact with agencies. They're frightened of them. They think, for example, if you present your child and your child is in a really bad way, physically, you know, with health or dental health, then the child's going to be taken into care maybe. So those sort of people will avoid contact.
So I think what you're describing is possibly children where there might be some safeguarding concerns around the care of those children. So if I just start with health visiting services then, so they operate as a universal service, and those 5 mandated visits are offered to every single family. It's expected that a health visitor will see that baby at least 4 antenatally, and then 4 times until the baby turns age 5. Where our health visiting workforce would have a concern around a family, either because they're not engaging with their services or anything else that might cause concern, then there'll be established process, which might be what Anthony was coming in around about how we'd respond to any safeguarding concerns for and with that child. So health visiting as that universal service offers that kind of backstop there as well. You'll be right that sometimes poor oral health is used as a marker for neglect. That's understood, seen and responded to, I think, with our safeguarding teams as well. So that's perhaps one, if more information is needed, then we could ask our safeguarding children's teams for more info there. But I think Anthony's coming in.
Yeah, that was the point I was going to make actually around our safeguarding teams, but also I think the point is well made from Councillor Knowles that the system needs to be linked up, doesn't it? So that all our professionals have the ability to identify our most vulnerable people and access dental services accordingly. One example of that would be our Gypsy Roma traveller link workers, which are having great success across Doncaster in the work they're doing. We presented previously at the Health and Wellbeing Board, and they're increasingly finding issues of oral health among those communities, and we've made sure that they have the right links into the access of services. So the point's well made. This is about making sure all our services are linked up to be able to access what services we've got.
Thank you.
So that's the last of our questions. We haven't got any recommendations around dentistry. I think, as has been previously said, our figures were better than the rest of South Yorkshire, but obviously that's no reason to take our foot off the accelerator. I think the overseas recruitment could make a huge difference, as it has in other areas in the NHS with very good success. And I think the flexible commissioning will make a difference. I think the fact that we very quickly had a South Yorkshire conference on dentistry was very positive, and some of us on this side attended and were really, pleased that we did. We did have 2, or did we have 3 dentists sitting with us? So that for us was very positive and gave us a lot of information. So we haven't got any recommendations, but we would like at a future point an update on the outcomes really, and how Doncaster continues to do with dental care. And the only other thing I would add is that the recommendations for primary care access from the panel, so what we're looking at really is to have a digital focus on future plans, better outcomes for the NHS app.
Better communication. Yeah, sorry, Anthony mentioned something about communications, just to seek clarification. And then it were outcomes.
Yeah. And the third one was an outcomes update so that we know at some future point how those things are going according to plan.
Sorry, I just want to check, because what I'll do is a letter with all this, just outlining key points and what the panel's asking for the future. So I just want to check the better communications, is that mainly about the app or generally?
I took that to be a general point, actually, around linkages of communications across our different providers and services. So
Right.
I think that relates to all three of the contracting areas that we just discussed.
Okay, so general one across all areas. And Chair, just might be worth seeing if the panel agree with that as well.
And the panel agreed with those points. Thank you. And, you know, we do appreciate that currently things are coming out of government on a daily basis that makes a difference to, you know, how things are happening, although no information as yet on whether it's new or old money. So we do appreciate that. So we'd like to thank everybody for taking part this morning, and we're going to move on now to our scrutiny work plan. Thank you.
Thank you. Before we just get onto the work plan and forward plan, I do want to just put in Councillor Linda Curran's apologies, who may not be here for the next couple of meetings, so I just wanted to include that. So moving on to the work plan and forward plan, it's end of your agenda pack. It won't be too long, this, so we've just got one more meeting in March, where we'll have the annual update on public health protection, so that meeting's dedicated to that. Which should be always a good discussion like today. And there was one more thing. So of the forward plan, the local account went to Cabinet, and I did circulate a copy to the panel. So I just wanted to mention that that action's been done. Finally, what I'll do, I'll make sure from today, so it's been for next year's work plan for consideration as it's to be agreed, that we ask for those updates and those outcomes from the three areas, with a focus on the digital element as well. So that basically concludes what I need to say, Chair.
So that concludes our meeting for today. Thank you.
Thank you, everyone.